Welcome to Medical Mondays, and welcome to another evening of getting fed, getting educated, and taking care of our health. We're excited tonight because we're going to talk on what is ailing our country and our planet as a whole, COVID-19. I'm Dr. Toyin Opesami, a family practitioner, HIV specialist, and I also treat addictions. I am in private practice in Maryland. Everything we're doing on Medical Mondays is free of charge, and we are not establishing physician-patient relationship. We are disseminating excellent medical information and giving you the opportunity to ask questions, to grow and to learn how to, better take care of your health, to accord you a strong health and a strong future. So tonight we have Dr. Mohan Amlani, who is a friend of mine, and I'm very blessed to have him come to talk to us about COVID. He's an infectious disease specialist, and he did medical school in India, residency and fellowship at State University of New York, Stony Brook. He practices in Baltimore, and he's been practicing since 2002. I have personal practice relationship with Dr. Amlani, and I know that he's one of the top in the line. He's one of the top of our infectious disease physicians. So we're in for a treat tonight. So Dr. Amlani, welcome, sir.
Oh, thank you. Okay, thanks for having me. Yeah.
So I'm going to share Dr. Amlani's screen. Can everyone see that?
Yes.
Fantastic.
Okay, so I'm going to just speak for a few minutes, talk a little bit about what's going on with COVID, and I'll be happy to answer a few questions. I'm sure you all have a lot of questions for me. Yeah. So let's go to next slide. So I'm sure everyone is aware this epidemic started in China in 2019 and then spread worldwide. More than 200 million cases reported worldwide and responsible for more than 4 million deaths. US had 35 million cases. Can you go to previous slide? Yeah.
Previous slide. So.
Yeah. Yeah, you're moving too fast. Yeah. So 35 million cases reported in US and 600,000 dead so far. I'm from India, so I know they have reported 31 million cases, but I'm sure the number of cases are probably 10 times what's reported. And they have reported 400,000 deaths, but I'm sure it's more than a million. So I think probably India has highest number of cases in the world as far as COVID is concerned. So next slide.
Next slide.
Yeah. And a few things about transmission. I'm sure a lot of controversy is going on about transmission. We know it's all transmitted by droplets. There were some questions regarding whether it's airborne transmission, but so far we don't have any definite evidence it's transmitted by airborne. We also know that it lives on, or it can survive on surfaces for many days on steel or plastic, but so far we haven't seen too much transmission from the surfaces. So most of the transmission we see is from person to person. So it's very important to wear mask. Um, I think that's the most important thing. Yeah. Next slide. I don't want to go too much into detail, but I'm sure everyone knows about the symptoms. People can have fever, malaise, body aches, headache, running nose, loss of smell and taste, um, cough and shortness of breath, vomiting, diarrhea. So those are the most common symptoms. So the question is, when to speak to your physician when someone has the symptoms. Previous slide, please. Previous slide, yeah. So a lot of, what we have seen is people come to hospitals late in their disease, and it's very difficult to bring them to normal. So the most important thing is, when to consult physician. And as far as I know, as soon as you have symptoms, you need to speak to your physician. And one thing we haven't used too much is monoclonal antibodies. And this is, to me, it's the most important medication and treatment of COVID because you can prevent hospitalization. There are two different monoclonal antibodies available, one from Lilly and one from Regeneron. And to me, anyone who has COVID should be getting monoclonal antibody, even with very minimal symptoms. Right now, it's reserved for high-risk individuals only, especially patients with diabetes, renal failure, and any immunocompromising conditions such as HIV or any rejection medication. So you can go to the next slide. And the question is when to go to the hospital. And whenever oxygen saturation goes below 93 to 94%, I advise patients to go to the hospital. And that's the one thing we have been advising patients to go and buy a pulse ox machine or a pulse ox oximeter when they have COVID, and they had to check it every few hours to make sure their oxygen requirement, or the patient doesn't need any oxygen and their oxygen saturation is more than 93, 94%. They should go to the hospital as soon as their oxygen saturation drops below 93 to 94%. And persons who don't know, treatment for COVID, we usually give remdesivir as well as steroids, and usually give remdesivir for 5 days, and steroids we can give it 5 to 10 days. The one medication which I like the most is called tocilizumab. It's a IL-6 inhibitor. It's recommended for patients requiring oxygen. So as soon as the patient meets criteria to be admitted to the hospital, they are a candidate for tocilizumab. And I'm sure everyone knows COVID or COVID-19 or SARS coronavirus 2, when it multiplies or binds to the epithelial cells in lungs, it releases cytokines, and IL-6 is one of the most common cytokine released, and it's responsible for a lot of damage to respiratory epithelial cells. So this medication is very important, and unfortunately, it's very expensive. A lot of the hospitals, they do not want to dispense. But to me, it's one of the best medication for treatment of COVID-19 infection. There is another oral medication that's called baricitinib. It's one of the cancer drug, basically. It's a Janus kinase inhibitor, and it's also approved, but not very well studied yet. There's a lot of controversy about use of hydroxychloroquine and ivermectin. I'm not a big fan of it. I haven't seen too many patients getting better. We were prescribing in the beginning, but I haven't seen any benefit of hydroxychloroquine, and none of the studies have demonstrated any benefit. Same thing about ivermectin. I haven't prescribed any ivermectin, and I don't think studies have shown any benefit. Next slide. So I'm sure everyone knows about prevention. There are 3 vaccines right now approved in US. And most of the vaccines are very effective, more than 90% effective in prevention of severe disease. The Pfizer and Moderna, their mRNA vaccine versus Johnson & Johnson, which is a recombinant vaccine containing adenovirus with spike protein, and it's a single dose vaccine. There's a lot of controversy about it's responsible for clotting disorders such as immune thrombocytopenia, but it's very rare. And as I mentioned here, it's the incidence is 1 in 500,000. So it's very rare. It's more common in women of young age, below 50. So it's very safe and effective vaccine. Next slide. So now I'm going to talk about variants. That's what we are dealing with right now is Delta variant. This was first reported in India in December 2020. And now it's predominant strain in the US. More than 80% of infection in US currently are caused by Delta variant. What's strange about or scary about Delta variant is it's very infectious. It's 3 times more contagious than the original coronavirus. We call it R0 or reproduction rate. It's 9. So 1 person with SARS coronavirus 2 infection with Delta variant can infect 10 other people. So it's 9 to 10. It's as good as, I would say, measles or smallpox, So it's very, very highly infectious. And severity is a little bit higher too. I'm sure everyone knows a lot of children are infected right now, and southern southern part of the country, especially Florida, Georgia. But good thing about is the vaccine is very, very protective even against Delta variant. So next slide. Other variants of interest, they call it variants of interest, are Alpha variant, which was first identified in UK. It was prevalent, very prevalent in May or in June in US. It was responsible for close to 70% of cases in US, but now it's taken over by Delta. The other variants of interest are Beta variant, which is identified in South Africa. Luckily, we haven't seen that variant here. Gamma variant, which is common in Brazil, but also we haven't seen too much. Next one. Other variant of interest is Lambda variant, which is first identified Peru last year. And it's prevalent strain in South America. So we need to be very careful traveling to South America. We don't know too much about Lambda variant yet. We haven't seen too many cases of Lambda variant in US. But one thing we know that it requires very high neutralizing antibody titer in order to contain it. So we still don't have enough data, but it's possible that it may be resistant. Just, and hopefully we won't see it in the US. Another similar variant is Epsilon, which is identified in Pakistan, and it's also known to be resistant to vaccine. So, you know, we haven't seen too much. I don't want to predict anything, but we don't have too much data, and so far we don't have to worry about it at this time. So, next slide. There's one question, you know, many physicians keep on asking me about antibody testing. The question is whether to order antibody testing to see if someone has antibodies after vaccination or after infection. And if you go on the CDC website, they recommend that testing is not recommended to assess immunity against COVID-19 infection, person with vaccination or infection. So at this point, you know, only reason to get antibody testing is if we suspect a patient had infection in the past and you want to make sure if they had persistent symptoms, they are probably from COVID. That's the only recommendation for antibody testing is if patient never been tested before and they have some kind of symptoms, they think it's from COVID in the past, we want to make sure it's, you know, they don't have antibodies to suggest. So I don't routinely order antibody testing. Only time I have ordered it when the PCR test is negative and you strongly suspect COVID infection. I think that's it. Yeah, I'll happy to answer any questions.
Thank you very much, Dr. Amlani. Thanks for the, you know, the background, which is, you know, all we can do when it comes to COVID dialogue right now is just to give the background of what we have at hand and, you know, where we're going. So I'm going to ask you a question.
Sure.
Before we go to the chat. You said, you know, monoclonal antibody is your most favorite treatment for COVID for those who are infected. Mm-hmm. And in the same token that it's readily available to people with underlying medical problems like diabetes, cardiovascular mm-hmm. disease. So what does the layman do? Because you did say even if they have minimal symptoms, you recommend that they get the monoclonal antibody. So how readily is that, and how can one navigate getting it if one is infected?
So I don't know right now, but months ago, Department of Health was administering it. So we had to just refer them to get antibody test. It was on the Department of Health website. Actually, I referred for a few patients. You just had to fill out information online, and Department of Health were contacting the patients to get it. It was, most of my patients received within 48 hours of referral. I don't know the situation right now, but I know some of the hospitals are giving it in the emergency room. I know Baltimore Washington Medical Center, they are giving it in the emergency room. So you had to probably check your local hospitals, whether they are administering in the ER. So it's readily available now. We know we have enough stocks, and we don't have too many patients right now. So I'm sure it's readily available. It just I know Baltimore Washington Medical Center is administering in the emergency room, so you just have to refer them to get it in the hospital. Yeah.
Fantastic. We are blessed in Maryland because by, I think it was July 4th, 75% of Marylanders have been immunized. However, I have personal friends who have been fully vaccinated and just came down with COVID in Maryland. So can you comment on that, please?
So if you look at the study of the efficacy of vaccine, if you look at the study, there were probably around 15,000 patients in each arm of patient who received vaccine versus persons who received placebo. There were still close to 100 patients in vaccine arm had COVID. And the good thing about those persons who received vaccine were none of them were hospitalized. So, we know even someone has received vaccine doesn't mean they're not going to get COVID. So it's not 100% effective. We know the efficacy is close to 95%. That's why they say it's 95%. So 5% of the individuals who received vaccine, they are at risk of getting COVID. So it's the good thing about it is it's not as kind of severe disease. Even if you say Johnson & Johnson, they say it's 85% effective and close to 95% in preventing hospitalization. So still 15% of the patient can receive, 15% of the individuals who receive vaccine, they can still get COVID. So it's not 100% effective.
Well, thank you so much for that answer. If you have questions, please write it in the chat box or just raise your hand and you'll be able to ask it, yourself. That is even better. I like that better. There's a question in the chat box asking if the monoclonal antibody is covered by insurance.
It's not, I don't think, but it's available free. So I don't think even the hospital has to bill. So yeah, it's kind of sponsored by the government. So it's there's no charge for it.
Yeah, that's what I thought. That with treatment right now, there's no charge. People don't need to stress about having insurance or not.
Yeah, it doesn't matter. Yeah.
Yeah. So you mentioned also treatment with remdesivir and steroids. What about those not hospitalized? Because remdesivir is available to people in the hospital. What about those not hospitalized?
And so, as I mentioned, the one, people who are at high risk of developing severe disease, they can get monoclonal antibody as an outpatient. People who are requiring oxygen, they should go to the hospital. Between those, or people who are not at high risk and they're not hospitalized, basically they need symptomatic treatment. I don't think any of the other medication like hydroxychloroquine or ivermectin or they are probably placebo. So I think most of the patients, they just need symptomatic treatment.
Thank you. So Dr. Pierre appeared before the Senate last December. I think it was December 18, something like that, if I remember correctly, 2020. testifying that as a pulmonologist, they use ivermectin, and ivermectin was effective. And there were some studies from other countries, not the US, showing that early use of ivermectin actually helps people with COVID recover quickly. And it can also be used for prophylaxis. We have not done any studies in the US, have we? I don't know.
Yeah, I don't think, we know, like even if you look at the 100 patients with COVID, 90% of the patients, they are going to get better without any treatment. So giving ivermectin versus not giving anything, they're going to get better. They're going to get better. Yeah. So.
Yeah,
Yeah.
and that is the truth. That's the virus. We mainly treat symptomatically. The only virus we can actually cure is hepatitis C. Interesting in all these years. All the other viruses we still, just treat symptomatically.
That's correct. Yeah.
So the lambda and epsilon, we don't have those in the US. At least if we have them, they are not problematic right now, correct?
Right now, yeah. The Lambda, there were a few cases of Lambda last year in California.
Oh.
But at the time we didn't have
Where? Where in California? Where?
I don't know where. But there were a few cases reported in California.
It's why she's asking you.
Are you in California?
Yes, sir. So you tell me now.
Now, there were not this year. I'm saying last year we had few cases of Lambda. But we didn't have vaccine at the time. So, but luckily, it didn't spread too much, and so hopefully it's not as contagious as Delta. That's what we are praying for. Yeah.
Hopefully not, because the vaccines don't cover that. But
that's what we think, like as we don't have enough
evidence,
like in vivo. Yeah, we don't have any clinical data. We just have like in vitro data. Yeah.
So, but what we have seen is that even people who are vaccinated, like you said, they actually do better. They don't end up in the hospital.
That's correct.
So
yeah.
The vaccine is still protective, even if they fall into that 10% who contract COVID. They do better in recovery time, in the severity of the symptoms that they experience. Is that correct?
That's correct. I think that's why I highly recommend everyone to spread the news, talk to your family, friends, make sure they're vaccinated. We still have 30% of the healthcare professionals who are not vaccinated. It's hard to imagine. There was some data released recently from nursing home. They reported to CDC how many healthcare workers are not vaccinated, and it was very surprising to see 30% of healthcare workers in the nursing homes, they're not vaccinated. So, talk to your family, friends, and push them to get vaccination. Yeah.
So there's a question, and I'm not sure what this is, but I'll just ask you. It says, what is the basis for oral samples for PCR tests?
I didn't get your question.
What is the basis for oral samples for PCR tests?
Oh, PCR test. It's a very, even nasopharyngeal, this is one study which was published somewhere, I think in Clinical Infectious Disease. And the study was done in I think somewhere in Japan or Hong Kong, where they compare nasopharyngeal swab versus oropharyngeal swab. And the results were very comparable. So, nasopharyngeal swab is I'm sure you know it's not very comfortable. And so, I think a good oropharyngeal swab is as good as. You don't have to take it from the gum or from the saliva, but you have to introduce swab a little bit further in the oropharynx. So like from the throat, it's not as uncomfortable as nasopharyngeal swab. So, but no, studies have shown it's very comparable. Yeah.
Thank you.
Yeah.
This is a very important question here. Somebody who has Guillain-Barré in 2015, who wants to take the vaccine. The person has recovered fully from Guillain-Barré, but is it safe to take the vaccine?
As far as we know, yeah. Now, Guillain-Barré was from, do we know what was it from? Or was just incidental?
Well, we don't know. Well, they have,
Yeah.
so.
So far, we haven't seen too many, Guillain-Barré or, it's an autoimmune disease. So they are, yeah. But so far, there's no contraindication as far as Guillain-Barré or even people who had other autoimmune disease. I highly recommend to everyone to get vaccine. Yeah.
The person got Guillain-Barré from flu shot. According to the chat box.
Yeah, I would probably, tell the patient, pros and cons, risk and benefit. We talk about risk and benefit giving any medication. As long as you document, and the patient is willing to take risk, I would, if I was person who received, who had Guillain-Barré, and if I had to take COVID vaccine, I would take COVID vaccine. The risk of COVID infection is very higher than getting Guillain-Barré. So yeah.
I just got a follow-up question in the private chatted that you said that without treatment, not treating a patient with ivermectin or anything else because it's a virus, they will get well anyway. But then why are you pushing for somebody who has a Guillain-Barré from flu shot to risk getting COVID vaccine?
No. As I mentioned, like depending on how old the person is, but if someone gets COVID, the chances of complications are higher. Like it's 1 in 100 chance that he will end up needing ventilator, right? Compared to 1 in million, of getting Guillain-Barré. So you have to explain to patient, hey, if you get COVID, you have 1% chance that you are going to get on ventilator versus you have 1 in million chance of getting complication from vaccine. So yeah, so.
Well, we haven't seen any Guillain-Barré after vaccination in the US. I don't think, I've not read anything about that.
Yeah, there are not many cases reported, but we have seen in the hospital. People, not severe disease, but they come up with weakness, So there are some cases of autoimmune disease like polyneuropathy, myocarditis, I'm sure you know. So, but they are so rare, it's maybe handful of cases and they don't know, it's the same thing, the incidence of TBS or Guillain-Barré and in general population is that I don't think, vaccination increased that incidence. So it's very difficult to kind of pinpoint that was from vaccine, but, there are some cases reported, yeah.
So somebody is asking about future boosters. They said, any thoughts about future need for boosters?
So we don't know yet. It might be coming in a few months. We don't have. So far, there are 6-month data on Moderna vaccine that the antibody levels are holding up. So we don't have data, but once we see, if we see a lot higher number of cases um, of Delta variants in persons who are vaccinated, then probably NIH or CDC have to come up with the guideline. But if we don't see too many cases of Delta variants in vaccinated persons, then we may not have to. So I think we are still kind of keeping our finger crossed. Yeah.
So I saw something on CNN that says that the FDA actually, maybe in the next few weeks, are going to put out support for the vaccine, which will be really a game changer if that happens, because then more people will get the vaccine, is what is postulated. Because it says FDA approval of the COVID-19 vaccine could mean more people will get vaccinated for an unexpected reason. So we should stay tuned for that to happen in a few weeks, it seems.
Yep.
Another question says, is it safe for sicklers, those are people with sickle cell anemia, to take the vaccine?
As far as I know, I don't think there's any contraindication for patients with sickle cell disease. Yeah, I don't think there is any contraindication right now. Even patients with immunocompromised disease, with transplant patients, cancer patients, they pregnant women, so. Yeah, so far we don't have any absolute contraindication for COVID vaccine, except patients with anaphylactic reaction.
Yeah, that's true.
Yeah.
So another question says, can you please bring some peace of mind to people with underlying disease such as diabetes? Do you recommend the monoclonal antibody as backup? I guess backup without infection.
I didn't get your question. So
So
prior to getting COVID vaccine, prior to getting COVID infection?
yes, like prophylaxis.
But they should get vaccine, Vaccine is a prophylaxis. You don't need to get monoclonal antibodies. Yeah.
No, I'm saying this is Shade. I'm the one with, that was my question. So let me bring some clarity. So I've already taken my 2 shots. I'm vaccinated.
Okay.
But I heard you saying something, because every time I hear the word underlining, it's just like you're in a different, world. They put you in another category, like, oh, you're prone to this, even though you're doing everything right. So I just want some peace of mind. I'm like everybody else. I'm diabetic. I'm managing my life well, but I don't want this COVID to kind of throw me off course.
So if you get any kind of symptoms of COVID, you get tested. And if you get tested positive, go and get COVID monoclonal antibody. You don't have to get it before you get COVID. Let's put that way.
Okay. All right. Got it. Thank you. Yes, that's
So basically, it is not, it has not been shown. I don't think it's been studied. We don't see how that would help. The vaccine protects, not the monoclonal antibodies. Monoclonal antibodies is used to treat. And I think what one can do, anyone with underlying medical problem like diabetes, is actually to control the underlying medical problem. To treat the diabetes to go, to make sure your A1C is below 7, good diet, exercise, just to build up one's immunity, and they'll fare well. Don't be scared.
Thank you, sis.
So another question says, let me ask about the massive information block and persecution of doctors who questioned the jab. The jab is the vaccine. Dr. Amlani,
Sorry, I didn't get your question. What are you saying?
the question reads, let me ask about the massive information block and persecution of doctors who questioned the jab,
Who questioned the?
the vaccine.
Oh,
So, Demetrius, do you want to ask the question in your own words, or should I try explain what I think you're asking? Okay, so I think he's saying that doctors who don't believe in the vaccine
mm-hmm.
are being persecuted. And oh, go ahead. Yeah. Okay, he'll ask his question. I'm asking you to unmute.
Thank you, Doctor. I'm just asking in reference to any doctor early on that offered a treatment that would have been helpful in the beginning. They were either confronted by their own hospital administrators and told not to speak of it. I've heard reports in Minnesota of a doctor saying that the state board was going to decertify him because he was actually talking about a treatment. And until there's an open public debate without coercion from government authorities or the media, I can't believe anything that I'm hearing. So my question is, how do we get to the truth?
There's always some misinformation. You talk about any topic. If you go online about any disease, you talk about HIV, you talk about Lyme disease. There are a lot of controversies on everything. So I think the best place to go is go on best website like NIH. You go to like an infection. You have to go to Infectious Disease Society website and see what it is right. And yeah, I think so. The best way to do is you have to look at where the right information is. So if you go on Google, or there will be different options for everything. So yeah, you have to choose the right place, where to look for information. So yeah, like I don't know, who were kind of reprimanded for suggesting something, but like there are, there were even leaders, who were recommending something harmful things, So it's a kind of free country. People can recommend what they think is right, but doesn't mean it's true, or So I think the best thing to do is go on the right place to find out your answer.
Thank you.
Yeah.
So,
Dr. O, please, Dimitri has a second part question, which I'm interested in.
yes, ma'am, go ahead. Read it.
No, he said he has two relatives in Greece that after taking the vaccine, they couldn't walk. What do you mean they couldn't walk?
Dimitri, unmute.
Got it. My cousin, who's looking after my mother, her godfather, which I've met a few times in Greece, he had taken one of these shots within 2 weeks, and she told me that he actually needs help walking. He can't walk anymore. I don't know how severe this impediment is, but she told me on the same island that a 12-year-old entered a clinic to take the vax, and when she left in a wheelchair, and it caused quite a commotion in the neighborhood. But what I understand, I've heard a few reports, is that the adverse effects website numbers into 45,000 incidents, and the media is telling us it's down to 10,000. So I'm just telling you what's coming across my area, but these are two relatives. Actually, one's a relative and one's a neighbor. But the one godfather, I know him, I've met him. He's driven me around in his car, and I haven't been back to Greece for 2 years, but I have regular communication with my cousin. If you need more details, I'll ask. I'll see if I can find more details, but that's what I know right now.
Yeah, that would be helpful, but probably not at this forum, but it can be passed down to Dr. O.
Sure.
So Dr. Amlani, what is the remote chance that this subsequent condition that these people experience had to do with the vaccine?
So I was just mentioning about Guillain-Barré, or polyneuropathy, and personally, I have seen a patient who received vaccine, and a few days later, he had difficulty in walking. So the question is whether it's related to vaccine or it's incidental. Probably you can look it up. Chances of developing polyneuropathy is probably 1 in a million or 1 in 100,000. So they were going to get it by anyhow, or it happened after receiving vaccine. There is always a chance, but as I explained to you earlier, you always have to look at risk and benefit of anything, so chances of having, severe COVID infection is higher than having this kind of adverse reaction, which is 1 in a million, So, yeah, so, there's always, like, you think about this clotting disorder, there were 20 something cases reported so far with Johnson and Johnson. There may be 100 cases. But so there are always risks for some complications. So you always have to weigh benefit and risk of everything. It's like driving a car. What are the chances that you're going to run into accidents? Yeah, there is chance. But you're not going to stop driving your car. So it's a similar situation.
Thank you for that. I will say, like Johnson and Johnson, people started talking about this blood clot. It was a shame that Johnson and Johnson was actually shut down by the powers that matter, because on CNN, everywhere you read it, it says real blood clot. And yet it was propagated as if, everybody that gets it get this. I think the shutting down of that vaccine for that period of time caused problem because people just, took it to mean all the vaccines. Because in Greece, we don't know what kind of vaccine they got. The chances of adverse effect is possible with anything. In this case, we don't know what kind. Like in Nigeria, it's AstraZeneca that is prevalent. I believe now President Biden has been so kind to donate Moderna to Nigeria. One of my professor friends told me that yesterday, which is great, but they have AstraZeneca that has a totally different adverse effect profile from what is available to us here. So it's rare. It can occur. It does occur, but it's rare. There's another question that says, can you please explain the definition of a vaccine? I think that one that's an excellent question also. And that's Demetrius. Please explain the definition of a vaccine.
Definition of a vaccine, it's a kind of any substance you receive to prevent certain disease. It could be inactivated virus or inactivated substance or something similar to the disease you are trying to prevent. So it's kind of any preventive medication which is similar to the disease you're trying to prevent.
Yeah. Geez, I've never had it said like that before. That is excellent. but if I can, maybe go a little bit further to, to just dive into what vaccines do. And when we talk of vaccines, generally, like it says here, like vaccine against measles, mumps, rubella, varicella, um, and all of that. What they actually do is go into the body and mimic what you're trying to prevent. When the body sees something like that, it's foreign to the body. It's an alien to the body. So the body is going to come out and fight. When the body fights, what it produces to fight whatever this invader is in the body is antibodies. So the body produces antibodies against whatever this agent is. It could be virus, could be whatever the vaccine is made for or made against. So when the body sees the culprit again, the body will remember. I've seen that one before. I have the soldiers, the antibodies, to destroy it, and it will. And then you don't get the you don't get the disease or the infection, whichever case it is. In the case of COVID, these vaccines go in and produce what is called a spike protein, which is what COVID produces in the body, and that then infiltrates the cells and cause all the problems that occur in COVID. So the vaccines mimic that. They get into the body, they produce the spike protein, like protein. Dr. Amlani, do you agree with that? I'm trying
Yeah,
to.
so in short, yeah, we usually any vaccine has inactivated bacteria or virus, which is responsible for the disease. So, say coronavirus or COVID, you have spike protein, which is kind of main culprit, which is responsible for all the disease related to COVID. So we're trying to prevent this body's reaction to spike protein. So we have this all the vaccine which contains spike protein, not the whole virus. Same thing with say pneumonia. If you want to prevent pneumonia, we take part of pneumonia bacteria and then inject it, not the whole bacteria. So same thing with other bacteria and viruses. Measles virus. So we don't inject the whole measles, but we use like part of the measles virus and inject it, and body kind of tries to fight off producing antibodies, and this antibodies will prevent the disease. So yeah, basically you are exposing body to virus, but not like total virus. It's just a part of the virus. So.
Exactly. And you know what? While we're talking about that, the flu, some people get the flu shot and they say they get the flu after getting the shot. No, they don't. They get what we call serum sickness. It's the body mounting up antibodies against the flu. And that's why they got those symptoms that seem like the flu. It's not as severe as the flu, and it doesn't last as long as the flu to protect the body in case the real flu, in case they get into contact with real flu.
Yeah. So Dr. O, I have to leave by like in a couple of minutes. My battery is dying anyhow. So someone has any questions?
Let me ask you some questions, and I will try to take the rest of them the best I can. Dr. Ajagbe asked, what is antibody-dependent enhancement?
So antibody-dependent enhancement, basically, that's what they are probably trying to do with the booster vaccine. So we know, certain antibodies are protective, and the question is whether increasing antibodies, will enhance our protection. So Yeah, so it's a similar to vaccine, basically, whether, it- so by, exposing someone to certain virus or bacteria, we are producing antibodies, and that can improve your protection.
So how many more can you take? Somebody's asking if you recommend for someone who has lots of allergies
Mhm.
to take the vaccine.
As I mentioned earlier, we don't have any contraindication for vaccine right now. Yeah. So,
Well, I guess
uh,
the question stems from, remember when Pfizer started giving the vaccine in London, and two women developed severe, I think it was the Friday
let's say that,
that we started, and said that if you have severe allergies, don't take the Pfizer vaccine.
yeah. So it's a kind they had anaphylactic reaction. We have seen two patients receive, they develop um, anaphylaxis, So, but there's no way to predict, who is going to get anaphylactic reaction or not. So, um,
Okay, question concerning proper handling of used masks. Can the virus droplet stick to the outside of mask, and how long does the droplet stays in the air?
how long droplet stays? The droplet doesn't stay in the air. There's a difference between droplet and airborne. The droplet doesn't stay in the air for more than a few seconds. So yeah, it just kind of drops on the surface right away. Versus, airborne is usually circulates in the air. So we know COVID virus, it doesn't circulate in the air. It just drops to the surface very fast. As soon as they cough up, they start dropping down to the surface. Yeah.
So
And
airborne. So the airborne virus does not stick on the mask. I guess asking the
now,
another way.
now whether it sticks to the mask, if someone is coughing, yeah, it can stick to the mask, and yeah, but it doesn't penetrate in the mask. So um, yeah, but as we know, it's not transmitted by the surface. So even if it sticks to the surface, their chances of getting COVID from the mask is very low.
So I guess the advice then would be, when taking out the mask, take it out like this and dispose properly. Don't
That's correct.
all over the front of the mask.
Yeah, you try not to touch, even if you try to keep it on the surface, make sure you keep it outer surface on the surface and not the inner surface. So if you are, say, if I'm talking to you, I'm taking my mask off and leaving the outer surface on the table, not the inside. So, yeah. Okay.
Is
It's
that you,
not
Dr.
me.
Amlani? How many more,
Okay,
how many
just
more
one more.
questions can
Okay.
you take? I said, okay, I'll ask the next one. What advice can you give someone that has problem in walking after taking the vaccine, please?
Problem working?
Yes, after taking the vaccine, if they have difficulty ambulating, walking, what advice would you give them?
Oh, you think it's probably from the vaccine?
I'm just reading the question. I don't know. Well, I guess, extrapolating, yes, say they got the vaccine and have an adverse reaction
Mm-hmm.
and have difficulty ambulating. What advice would you give?
And how long it's been going on?
Sister Kende, she's actually, she zoomed in from Nigeria.
Oh, okay.
That's it.
Okay. Yeah, um, I can't think about it. Depending on how long it's been going on, people can get polyneuropathy or something. So they need to go to a hospital. That's what I can say, and make sure they don't have any kind of reaction to the vaccine. Yeah. But they shouldn't kind of stay at home. I would say, just make sure they haven't had any complication or reaction to vaccine yet.
So I think one more question. Can
Mhm.
you elaborate on the AstraZeneca adverse profile? We are in various countries. It's true. On this platform, we had somebody from Barbados,
Mm.
we have people from Nigeria, Liberia, all
Mhm.
over the US and Canada.
Mm.
Welcome again, everybody. But somebody wants to know, I think this person is from the UK because we have people from the UK too.
And the question is, like if they have AstraZeneca vaccine?
What can you elaborate on the AstraZeneca adverse profile?
Adverse profile.
What effects can one see after getting
I
or
think
with AstraZeneca vaccine?
I think AstraZeneca and Johnson, they are very similar vaccine. So, they had few cases of hypercoagulable state or thrombocytopenia. So they have a very similar profile. So um, I can't think about anything else, other than this incidence of hypercoagulable state. So.
Well, during the research process before AstraZeneca actually was widely now given, there were reports of Guillain-Barré.
Yeah.
In fact, at
But-
that time, they altered the process.
But there are a few cases of everything you can think about. It's autoimmune thing. People who I can tell you I have seen cases with mRNA vaccine. With Guillain-Barré. So it's polyneuropathy. It's all autoimmune disorder. They can happen, but the incidence is probably similar to hypercoagulable state. It's antibody mediated. We know that hypercoagulable state is antibody mediated. It's antibodies to platelet factor 4. So it can happen. It can happen maybe 1 in a million. So yeah.
So people are asking for your contact. If you please put that in the chat box, please.
Chat box.
Somebody is asking that there should be.
Yeah, you can send my email. You have my email, right? So to everyone, yeah.
They're asking for part 2, please. They like to have MM.
Okay.
I think it's Amlani at Gmail, right?
Yeah. Mm-hmm. Yeah. To everyone file.
Okay.
Yeah.
I put that there. So you did awesome, well, Dr. Amlani. Thank you so much. You answered all of the questions that we have here.
Okay. Yeah. Feel free to email me if you have any more questions. Okay.
So what would be your, parting words for us tonight? If, what you want us to take home regarding.
Take home, as I mentioned, I forgot to put it in the slide, but basically one thing, monoclonal antibodies for people who have minimal symptoms. 2, if they get hypoxic, go to a hospital. Number 3, vaccine for everyone.
Fantastic. You know what? This has been fantastic. And I just want to say that next week, we'll be having Dr. Kindred, who is going to be talking to us about hair and nail problems. Have you noticed how many men, even young men these days, are getting bald? It bothers me. I look around and I'm seeing young guys in their 20s getting bald. Dr. Kindred specializes just in hair and nails, and she's going to give us an awesome time. I'm looking forward to that. Make sure you come. And this week, when somebody brings 10 or more people to the platform, we actually give them, we call them VIPs. Dr. Ajagbe has been a champion who brought to the forum one time over 20 people. Tonight, we have Dr. and Dr. Ajay winning a VIP, and they will be giving a gun. to the forum and they come, email us, because we email you. You have our email address, medicalmondayswithdro@gmail.com.
Great. Thank you.
Thank you so much.
Okay.
And yes, if everybody will please on session.
Okay,
Thank you.
Okay.
Thank
Thanks
you.
for having
Dr.
me.
Amlani.
Thank you.
Thank you.
Thank you.
Thank you.